अरे बाबा कदली पत्र
सुमन्यु को
कंचा करिवो तमे
Sumanyu, just mute your microphone. No?
All right.
Good morning, everyone. We welcome you all to OrthoTV online in a new series, Trauma and Deformity. And to introduce today's topic and the panelists and speakers, I hand over to the mentor of them, Dr. Mangal Parihar from CLLR.
Good morning. Good morning, everybody. So the idea for this was for us to try and share in terms of the things that we are doing with the Ilizarov method. We've had at Mumbai, we've had more than I think 20 fellows now, most of whom who are doing independent practice at their individual places, and therefore to see and show what they are doing, and in that process try and bring about some more spread of knowledge related to the Ilizarov method. So today the people that we have discussing their cases are Dr. Saurabh Anand, who is from Kishanganj, Dr. Rajiv Gupta, who is from Kurukshetra, Dr. Hitesh Singhal, who is working in Jodhpur, and Dr. Kumar, VSV Kumar, who is in Chennai. So the way we are going to do it is they will present their case, then we will discuss that case, and finally, once these 4 case presentations are over, Dr. Divya Ahuja from Mumbai, Divya works with me as a colleague. He will present a case or some principles that we are following, and then we will have a discussion on that. So to start off, I will invite Dr. Saurabh. Saurabh, you need to unmute yourself.
Yeah, good morning.
Yeah, and share your screen. Once you have finished speaking, just unshare your screen so that the next person can get it ready.
Okay, sir.
Okay, go ahead.
Good morning and a happy new year to you, sir, and everyone. Many thanks to Dr. Mangal, sir, for giving me an opportunity to present my case before you all. Now presenting my case, know when you can see my screen.
Yeah, go on. We can see your screen.
Yes, sir.
Click on the slide once and then it will go forward. Click once on the slide. Yes, or use your arrow keys. Yeah.
My patient is a teacher, 40 years of age, who met with an RTA 7 years back, sustaining closed fracture shaft of right femur that was treated outside by intramedullary nailing. Patient had history of seropulmonary discharge from his operative sites, both proximally and distally, which eventually settled with antibiotics in a time of about 4 to 5 months. He doesn't have history of discharge after that period, but he had persistent pain since surgery, which was initially more over at mid-thigh and in later years around the hip and flanks. He was taking analgesics on the regular basis, especially for his pain around the hip. This is his earliest X-ray I found, which is 3 years from the time of surgery. Both the proximal locking bolts have been removed in an attempt to dynamize the non-union site. In this X-ray, we can very well appreciate backing out of nail also. So he came to me like this. At this point, he was so troubled by his pain around the hip, he just wanted to get rid of the implant. So implant removal was done for him. This is the limb length discrepancy. We need to that much block to square the pelvis. And this is the picture after implant removal. There is established non-union, shortening of 6.5 centimeter, and possible infection at the non-union site. So these are the problems at hand. Debridement was done, edges were transverse, proximal osteotomy was done for lengthening. I put bone graft harvested from ipsilateral iliac crest. Final shortening after debridement came out to be around 8 centimeter. Regarding his intra-op finding, there was no frank pus, but plenty of unhealthy necrotic fibrous tissue was found. Culture didn't grow anything. LRS was applied, and this is his immediate post-op X-ray. Lengthening was started after a week. It went nearly smooth till 4.5 centimeter of lengthening. While distraction, I called the patient for follow-ups at 10 to 12 days. But this time, due to exams going out of his school, he came to me after a gap of little more than 3 weeks. And when X-rays were taken, it didn't look good. Region in quality and appeared to be vanishing or disappeared on the lateral aspect, and also it was looking angulated. Length achieved at that time was 6.5 centimeter. At this point, I felt it was time to take a decision whether to continue distraction or to stop it, looking at the already precarious condition of the regenerate. This is the X-ray I'm talking about. Now I decided to play safe, so I stopped distraction, compressed the regenerate a couple of millimeters, and put the patient on full weight bearing. Saying this, I mean I have accepted this amount of distraction as his final lengthening, which was 6.5 centimeter. That is 1.5 centimeter short of what I have aimed for. There were no significant changes in the X-ray for the first 2 weeks, but at the end of 1 month time, consolidation was very much evident in X-rays. This is his this is his walking video of that period. Now, this is X-ray 2 months from the time distraction was stopped. It's so definite improvement in consolidation, and as I've told, final length achieved was 6.5 centimeter. And this is 7th month and 11th month. Now the healing was going in an expected manner. At 13th and 15th months, the lateral aspect of regenerate never reappeared, but the medial part was healing nicely. Now, if we look at the non-union site, no appreciable healing was found in the first 4 months. But weight bearing had tremendous effect on healing of both regenerate and the non-union site. This is at 17th month, that is 3 weeks from today. Both sides appear to be healed well. This is his walking video of the last visit. Lurch is there, but he doesn't have got any pain. He was as such supposed to come for trial of fixator removal, but for some reason he didn't turn up. I'm expecting to do so in a week or two. So the problems remaining now are shortening of 1.5 centimeter. That can be compensated. I have decided to compensate by shoe raise and stiffness of knee. His pre-flexion was 110 degree and presently it is 35 to 40 degree. I would like to do an ITV release for him and physiotherapy afterwards.
Okay. So now, Saurabh, this is the last slide?
Yes, sir.
Okay. So you tell me, what, if you had to do this case again, what are the things that you would do differently?
Sir, if I go back and look at the X-rays of that time, when regenerative started angulating, I can make out that the proximal most two pins has got lysis there.
Okay.
And the patient also told me that he was having increased discharge from the first two proximal most two pins.
Okay.
And he was too busy to do regular dressings there. So I assume that due to lysis, there may be some loosening along with some strong pull of lateral pull of abductors. The strong pull has created some undue tension on the lateral aspect of the regenerate and causing its lysis and disintegration.
Okay.
This is I can think of.
More than that is the fact that there may be, just go back to that slide, the first post-operative slide.
Yes, sir.
Okay.
Yes, sir.
So here, if you see between the proximal fragment and the middle fragment,
yes, sir,
there is already a varus. Look at the lateral condyle, lateral cortex, and you will find that there is a little bit of varus there, which is compensated by a relative valgus in between the middle fragment and the distal fragment.
yes, sir.
So one of the reasons possibly is that it has already gone into a little bit of varus at the time of fixation. Now go ahead a couple of slides. You see where the proximal pin ends. Yeah, go one more. One more. Now here, as you pointed out, in the second in the third picture from the left.
Yes, sir.
Okay, you have lysis over here.
Yes, sir.
Okay, and possibly the pin has backed out
Yes,
a little bit. So as you said, there is not enough hold, right? So because of that, then you have less of a hold. So though the LRS is good, there are these problems and you need to take special care. I think one of the other things that was brought out by this is the fact that when you're doing Ilizarov, you have to have a constant follow-up. You can't have patient, I mean, which you've done, but this is something that we have to remember. We can't do a sort of surgery and then ask the patient to come after 1 month and 6 weeks. You have to constantly follow up, because of which you are able to catch the fact that this regenerate is not developing well. And if it is not developing well, then you kind of stop it over there till things improve. And it is not a problem to stop the distraction, because having a long non-union is a much bigger problem than having a few centimeters of shortening, So that is the other thing. Now, for this, go back to your last slide or the picture of his consolidation, which is the best. Yeah, okay, the 15 months is fine. Yeah. So here, you have a lateral defect. And one thing you must remember is that this portion can be a problem as far as future fracture goes, especially because he is in a little bit of varus. So if I were in your position, earlier, I would have done a bone grafting for this to get a healing portion which is equal over here, in the sense of get a nice and equal regenerate there, so that you don't get in this portion, so that you get equal healing there, right? So you have to be careful of that. And finally, just show me a lateral clinical picture. Any back? Yeah. Okay. Now you see here where you have put the fixator. What orientation you have put the fixator on?
Actually, one mistake happened during the surgery, sir. The assistant didn't put the teeth. I accept it as my mistake, but he didn't put the teeth clamps. So I had a very tough time putting the fixator in the first place. If it would have been a teeth clamp would have been there, it would have been a lot more easier for me to.
No, but what I'm trying to point out here is this is the dead lateral.
Yeah, right.
Okay, and your fixator is kind of anterolateral. If you see here, his patella is there, and so the fixator, normally an LRS, I would use either a dead lateral or a posterolateral. Posterolateral becomes uncomfortable, so you use a dead lateral. Here, the fixator is slightly anterolateral. That's probably one of the reasons also why you may have had a little bit of trouble, right? So I think that's a excellent case. 3-4 important lessons learned here. 1, regular and constant follow-up. 2, if you are having trouble, stop, wait and watch. Don't just keep going on. 3 is prevention of problems, which is what you did by stopping the distraction. And also now you need to consider whether or not, when you take out the fixator, at the same time you should add in bone graft into this lateral defect that is there to prevent any future sort of stress fracture there. And check in terms of the application that you are dead lateral, right?
Yes, sir.
So that's a good case. Now you can stop sharing your screen and we'll go to the next next case, which will be Rajiv. So stop sharing your screen at the bottom. Saurabh?
Yes, sir.
Yeah. Rajiv, you can share your screen and put your case on.
Good morning, all. First of all, I would like to thank Mangal sir for teaching us all these basics and giving me a chance to speak here. Am I audible?
Yes, I can hear you.
So today I'm going to present a case of congenital pseudarthrosis tibia and fibula. So first of all, a little bit about the disease, congenital pseudarthrosis tibia. It is a rare disease. The chances are 1 in 2.5 lakh children. Mostly involves distal half of tibia fibula. It's usually unilateral. The pseudoarthrosis happen after the birth because of the non-union. The pathology is there is a thickened hematoma. Hematoma is basically there is the fibroblastic invasion of the periosteum. Usually periosteum has type 1 collagen in it, but the hematoma has type 3 collagen, due to which these hematoma cells do not undergo normal osteoblastic differentiation. So in biology, there is a lack of osteoblastic activity by default. Also, there is a failure of formation of medullary canal. There are sclerosed ends. The tibia has bow, rounded, tapered. There is association with neurofibromatosis. Spontaneous fractures and refractures can happen along with the time, and CPT usually heals poorly with routine treatment. So my case is, it's a 4-year-old female. She was an adopted child, so no birth history was available. The parents noticed deformity at right leg at 2 years of age, but no treatment was taken as child has no trouble. So at 4 years of age, the child presented with history of fall and pain right leg. These were her clinical pics at the time of presentation. In the distal part, there is pain, tenderness, swelling. There is bowing of tibia in both the coronal and in the sagittal view. These are our X-rays. So the tibia and fibula, this is not normal. So first thing is clear that this is pathological X-rays. So on analyzing the X-rays, there is anterolateral tibial bowing, sclerosed fracture ends, there is obliteration of the medullary canal, and there is also sucked candy-like appearance of the distal fibula, which is atrophic fibular ends. So the diagnosis is congenital pseudarthrosis tibia and fibula. On inspection of the child, we find capillary spots, so the association with neurofibromatosis is made. We classify this disease. This is Boyd type 5 CPT or Crawford dysplastic type 2C. And as the age of onset is less than 4 years, it is termed as early onset in terms of Johnson with presence of fracture. So all these types have told us that this type of CPT has a guarded prognosis. So we have planned the case, how to proceed with this case, and we try to make everything in the very first go. So what we have planned is, we have to plan that we will excise the hematoma, all the pathological tissue around the non-union site. We will excise the sclerotic bone till normal bone ends will achieve. We will make some stable intrinsic fit so that internal stability will be there. We will plan the osteotomy of the shaft to restore mechanical alignment. Try to put an internal splint, either a tense nail. We will take cancellous bone graft from iliac bone. Try to achieve distal fibular synostosis by shingling, tibio-talus syndesmotic screw and bone grafting, and then put an Ilizarov fixation for axial and rotational stability. These were her clinical pics. These pics shows the presence of hematoma. There is a thickened sleeve around the non-union site. We have excised that hematoma circumferentially from the tibia as well as from the fibula. These are the clinical pics of taking graft from the supraacetabular region by the apophyseal split method. And this is the clinical pic how we have put Ilizarov fixator. These were her posts of X-rays. Let us discuss about one by one how we execute this plan. First of all, we have excised from the anterior lateral incision, we have reached the non-union of the tibia and the CPT of the fibula. We have excised the hematomous tissue and we have excised the sclerotic ends of the bone. Then we have made a stable intrinsic fit of the fragments. What we have tried, we have split the widest part of the bone, that is distal part of the bone, into two, anterior and posterior flaps, and invaginate the proximal part of the non-union into it, giving a double overlay like appearance. Then we have done the osteotomy of the shaft to restore mechanical alignment. Then internal splintage of the non-union as well as the osteotomy. This TENS has been inserted in retrograde manner. First of all, we have put TENS from the CPT site to the ankle, correction of ankle valgus while passing the nail from the ankle, and then put retrogradely into the tibia up to the tibial metaphysis. This intramedullary road prevents axial deviation. As the distal fragment is small, it gives additional stability to hold ankle-foot complex, and it acts as an internal splint even after fixator removal. So it prevents refracture. Then we take bone graft from the iliac crest as well as supraacetabular region. This graft adds biology to the CPT, and we have taken graft from the epiphysis split method. It's just like decancellation of the ilium. Then we have put graft, we have do the shingling of the lateral tibial cortex, put graft over that site, and put a tibio-talar syndesmotic screw so that cross union between the distal fibula and the distal tibia can be achieved. After that, we have applied the Ilizarov fixator. This is a 2-ring construct held by olive wires, 3 wires in both the rings, and one extra ring, and we have put one extra ring below the foot. This extra ring will defunction the foot, and during the weight bearing, the weight is not passing from the foot, the weight is passing from the ring. So Ilizarov fixator, we are able to fix small osteopenic fragment, distal fragment with this fixator, allows us to compress, allows us to leg length, to maintain leg lengthening if there is shortening, gradual correction of deformities, and is strong enough to allow weight bearing. So after 14 days, clean stitch removal. After 1 month X-rays, everything seems good. The graft is consolidating, the osteotomy site is healing. These were our X-rays after 2 months. The graft has been absorbed but consolidated well in the osteotomy as well as the non-union site. This was our video. The child was initially uncomfortable with the fixator, but slowly she learned how to be comfortable. This was her video showing how we allow her to bear weight over the ring. These were her serial X-rays, 3 months, 4 months, 5 months. The osteotomy site as well as the CPT sites got united with time. The lateral views. This TENS, which we have put intramedullary, it's getting migrated proximally with time. Here the tip is outside the calcaneum, but within 2 months the tip has been, that nail has been went inside the calcaneum. So these are the telltale signs of walking. We have put the leather splits. We have fixed the leather splits below the distal most ring. That leather splits has been. These were her X-rays after 6 months. Everything seems united, osteotomy site as well as the CPT site. So now we have planned to remove the fixator. We have done the stress test, remove the fixator. We have planned to remove this TENS and reinsertion of the long TENS. But in view of the short distal fragment, as the child is, both the growth spurts of the child is pending and the distal fragment is very small. So there is always a risk that this nail will migrate so much proximal that it will become proximal to the CPT site. So I have planned to put a long nail instead of pushing it inside the ankle and giving brace. These were our X-rays after removal. So if we analyze the X-rays, the cross union between distal tibia and fibula is not achieved. There is a fibular non-union, and also the distal fibular physis is proximal. So we have to monitor for the ankle valgus in such cases. These were her clinical pics after removal of fixator, and the brace and the ankle foot orthosis were made with a locked ankle. It's a PTP type brace. The child was walking well with brace. So these were the clinical pics 9 months post removal. Everything is good. There is no pain. Child is walking well. But on deep analysis, the right lower limb is going into valgus. There is a slight limb length discrepancy as judged by the Alice test. These were our X-rays 9 months post removal. The nail has been migrated proximally deep into the calcaneum. No cross union between the tibia and distal tibia and fibula. On analysis, we have found that the right tibia is going into valgus, but most of the valgus is coming from the knee. There is limb length discrepancy of just 4 mm. And the problem is child is not wearing brace. She's walking without brace from last 6-7 months. So we motivated the child to wear brace. In future, I have to look for migration of tens. Either I have to change the tens to a longer one, or whenever it reaches into the talus, I have to push it more proximally into the distal physis so that injury to ankle cartilage should be avoided. I have to monitor valgus, may need growth modulation of the proximal medial physis or the distal tibial medial physis to prevent valgus. And I have to monitor for limb length discrepancy, may need lengthening. So the take home message is, in CPT, good planning is half job done. It needs stability and biology both. And always try to achieve distal tibio-fibular synostosis. We are not able to achieve this in our case. Always put an internal splint and don't remove it till maturity. And this CPT union needs to protect with brace till maturity. So thank you very much. And thank you for your kind listening.
Thank you, Rajiv. So
thank you, sir.
The lessons that you learned from this was in terms of, try to do everything. And that is exactly the message that pediatric orthopedic surgeons will give. That is the CHOI 4-in-1 principle. You got to do everything possible to get this to heal. It is not necessary to try and restore length, because getting union in these patients itself is a sort of big deal. A couple of things that I will sort of disagree or advise on. One is that, as you pointed out already, that the valgus now is coming from the proximal tibial metaphysis, and this was there even before. If you look at our pre-op pictures and analyze them, you will find that there is a proximal tibial valgus to start with.
Okay, sir.
And this existing deformities can create again abnormal stresses, and therefore the tendency towards a fracture. So I would probably do a growth modulation for the proximal tibia earlier rather than later, right? So that her axis is neutralized. And to make it clear to all the other sort of non-Ilizarov surgeons who would be listening, the Ilizarov here we are using only as a fixator. We are not using any of the Ilizarov principles of regeneration here. We are using standard sort of principles of pediatric orthopedic surgery, and using the Ilizarov because it allows us to control the rotations very well, and also allows us to extend the fixation into the heel if required, right? If it's a very, very small. Now, regards your comment about the internal splint, what I would do is, as soon as union is healed, union is achieved, I would take out the tens nail and replace it with a tens nail which goes just into the tibial physis. Because now, for you to take out that nail is going to be a big issue. There's no way that you will be able to take out that nail unless you dig heavily. If you try to take it out from the proximal end, you run the risk of breaking things again. So now you have to wait till she grows enough, hopefully, and it goes up. Putting the nail through the ankle itself, there will be a sort of what do you call argument that you are damaging the ankle cartilage. That to a certain extent is true, but you have to balance the difficulty of getting union versus the problem of ankle mobility, and getting union in these is very, very difficult. So I think overall, now once you've got this healed, it's not going to give you too much of trouble. So that's a good case, and you need to keep a watch on it.
Thank you, sir.
If as and when things develop. So you can stop sharing, and
Okay, sir.
Who's going next? Kumar. Kumar will show us a congenital pseudarthrosis. Meanwhile, I'll address some questions which have come up on YouTube. Amar Soni from Dahod says, this is in relation to the earlier case. I think Rajiv's stuff will come later. So he says, how to address hip varus. Another issue is healing index around 3 months. Please suggest measures to reduce it. So I think in relation to the varus, we talked about that the varus has come about possibly one because of it was fixed in a little bit of varus and then there was instability. So one of the measures is to prevent varus to start with. Number 2 is keep a close check on the pin side care and avoid the infection and loosening. In relation to which KK, Dr. Krishna Kumar Mechur has talked about using a HA pin, hydroxyapatite coated pin. Now, hydroxyapatite coated pins will give you better bonding and lesser chance of loosening. And one of the objections to a hydroxyapatite coated pin is the fact that they are costlier than standard pins. But if you look at the overall time period and the time that the fixator needs to be in place, especially if there is some element of osteoporosis, etc., there is definitely a role for hydroxyapatite coated pins. Ankit asked Saurabh, Dr. Ankit Chavan is in Udaipur. Dr. Saurabh, there appears to be recurvatum at the docking site in the 15-month X-ray. Do you think it will have a bearing on final functional outcome? Probably a mild amount of recurvatum is not going to be too much of a problem. The other thing is the femur is bored. And whenever you have a gap and you want to fit this bored thing into a straight fixator, there will always be an element of recurvatum. The normal anterior bow of the femur is lost. And that doesn't really have a gross functional effect because it is in the plane of movement of the knee. So that is compensated fairly well. Yes, if it is excessive, then it can cause trouble, but a mild amount will not. And finally, I think someone on the chat, Sumanyu said, could you have done antibiotic coated nailing followed by lengthening at a later date? Always. I mean, there are multiple ways to skin the cat, but here antibiotic nailing usually is something which is required for intramedullary infection, and this guy didn't have intramedullary infection by evidenced by the fact that his debridement, after his debridement, infection has not been a problem. So yes, you can do that in 2 stages, but it's not absolutely necessary. Now, in relation to the CPT, Ankit has asked 2 questions. Which is the better option? One, non-union is united, keeping the once the non-union is united, to keep the retrograde nail or replace it with tibial nail, telescopic, non-telescopic, and free up the ankle. So putting in none of the Indian telescopic nails really work as advertised. So what I do is I take a shorter nail, I pull out this long one, and I put in a shorter one so that the end is just flush with the tibial epiphysis. That way you free up the ankle. His issue was in his sort of, what's the word? What Rajiv was saying is that it's a small distal fragment and therefore I kept it on. But I think even if you have a tens nail in that small distal fragment and not holding the ankle, once the non-union is healed, that serves as protection enough. Again, he says, I've replaced the tibial calcaneum ring in one case after union and Ilizarov removal with a tibia intramedullary nail, had also migrated into the tibia with time. Patient has started developing ankle valgus. I didn't understand this question very clearly. Ankit, you can put up the question again and then I will repeat it after the next talk. Ajay, India, I don't know who this is, whether this is Ajay Abrol. What's the experience with pin track cite pain in the CPT girl. Rajiv, what did you find?
Really, sir, initially she was afraid of all the rings and wires, but there is little incidence of the infection as well as pain.
Yeah.
After 6 weeks, the child becomes totally comfortable. She was moving her legs freely with fixator, walking on it. There is no incidence of any pain and.
I agree with that. If you have fixed it well, then pin site pain itself is not an issue. I've had in one patient, I've had a problem with pin site infection, but that was more related to the way the pin sites were being taken care of. And that is one more thing to remember in CPT. These holes fill up very slowly. So we never use Shan's pins with the Ilizarov. It's always an all wire frame, and you use olive wires to kind of improve the stability. Fine. So we'll come back to any more questions that come up. Meanwhile, Kumar, you can start with your presentation.
Yes, sir. Good morning, everyone. I would like to thank Mangal sir, my mentor, for giving me this opportunity. I would like to present.
One sec, just a minute. Now, for everyone who's talking further on, cut out the thank Dr. Mangal Parihar, because what I've done is teaching you all is sort of my duty, and calling you all to speak is also something that, okay, we want to share information. So there's no need for a thank you. Now go ahead.
I would like to present a case of a relapsed CTEV, which was managed with the Ilizarov fixator and an OrthoSUV. It was a 15-year-old male who came to me with his parents with a deformity in the right ankle and foot since childhood. They gave me history of serial casting and surgical soft tissue release done at the age of 3 years, but they didn't adhere to all the bracing protocols, and they have noticed a relapse of the deformity in over 6 months. So from the age of 4 years, patient was walking with a deformity in the ankle and foot. On examination, he had a fixed equinus of 45 degrees. Hind foot was in varus. He had a cavus. Forefoot was in adduction. Spine was normal. A scanogram was done to see whether there was any coronal plane malalignment and any limb length discrepancy. This is a clinical picture and a scanogram. You can see his hind foot in equinus. You can see the cavus and the hind foot in varus. These are his X-rays. These are weight-bearing X-rays of ankle AP and lateral. You can see the foot AP and oblique weight-bearing X-ray. You can see the forefoot in adduction. At the lateral view of the ankle, you can see the inclination of the calcaneum. It is decreased. You can see the equinus of around 45 degrees. That is his clinical picture. The picture on the right, you can see the old posteromedial release, which has been attempted when he was in childhood. So the plan was to do a percutaneous TA lengthening and a gradual soft tissue correction using an Ilizarov. So patient was taken up under spinal. First, a percutaneous TA lengthening was done. Since he had hind foot varus, it was in a step ladder pattern, starting from the medial side, medial, lateral, medial. Then the fixator was mounted in the deformed position. So it had a proximal ring block with 2 rings and a 5/8 ring in the calcaneum and a full ring in the forefoot. So these were the X-rays after the fixator was mounted. So in the ward itself, since there was no bony, osteotomy or bony correction plan, he was pain-free with the fixator. So in the ward itself, the OrthoSUV was mounted between the proximal ring block and the hind foot 5/8 ring. And there was a hinge connecting the forefoot ring to the hind foot ring. So X-rays were done after the SUV was mounted, program made for correction of the hind foot equinus, varus, and to avoid translation. The OrthoSUV was between the hind foot ring and the proximal ring block. For the forefoot varus, it was a differential distraction. Since medial side was in varus, medial side I started at a higher rate, 0.75 mm, and lateral it was 5 mm, then increased to 1 mm per day and 5.5 mm on the lateral side. So it took almost 4 weeks for him to get his deformity corrected. So once the deformity was corrected, he was taken under short GA. The OrthoSUV was removed. His ankle was manipulated. You can notice as his equinus started correcting, you can see all the flexors, FHL and FDL, you can see all the toes going into flexion. So after manipulation, with the 10 to 15 degrees of more than neutral, the fixator was locked. So correction, it took 4 weeks for him. He was advised to be double the duration in this fixator position. He was taught how to do stretching of his toes. In the night, he was given a spring with a leather strapping to hold the toes up to the ring. So at the end of 3 months, fixator was removed. He was converted to a cast. It was a walking cast. He was in the walking cast for a period of 3 months. He was allowed to walk, play. The instruction given to him was every 3 to 4 weeks time, he has to come back with a broken cast. That indicates that he has been pushing himself, walking around, playing with the cast. So after 3 months of the cast, he was given a walking boot. It was an AF4 which was given. Initially, it was a flat bottom. You found it difficult to walk. Then I gave him a rocker bottom sole, which was easier for him to propel. So 1 year follow-up, when he had come back to me, this was his clinical pictures. You can see the hindfoot varus corrected. You can see this was the amount of dorsiflexion which was possible. So at 4 years, this was a recent clinical pic done 2 days back. This is his function. You can see the right foot. You can see the cavus is gone. This is his clinical pictures. A repeat scanogram was done. He had, there was no limb discrepancy confined to his femur or tibia, but overall length, there was 1.75 centimeters short. This is his recent vein bearing X-ray. It is with the normal side. You can see the calcaneal inclination and the metatarsal declination angle, which is almost restored to the normal side. You can see the foot varus, which is taken off. Reasonable position of his Mary's angle on AP view. You can see the first MTP subluxated. Actually, that was during the initial manipulation of conversion of SUV to the fixator. I had just done little manipulation of his toes. At that time, the posterior capsule had given way and subluxated, but since he was pain-free and there was no significant amount of deformity clinically, I didn't do anything to that. So you can see on the left, you can see the calcaneal inclination, which is 15 on the operated side. On the normal side, you can see 20. The normal range is around 20 to 26. You can see the metatarsal declination angle of around 15 degrees. Normal is around 13 to 23 degrees. You can see the AP view of the foot showing almost normal Mary's angle of 6 degrees. So this is his final clinical.
Great. So excellent case with all the sort of requirements, pre-op pictures, intra-op, what was done, and most importantly, long-term follow-up. So one thing I think the sort of was not clear was, Kumar, we do
Yes, sir.
deformity correction with the Ilizarov. And
Yes, sir.
there we do all kinds of fancy planning to get the cora and the hinge, etc. So in this particular case, did you do any planning like that, or is the principle here slightly different?
The principle here is slightly different, sir, except like in the conventional Ilizarov, to correct the equinus at the ankle, where to avoid the anterior translation of the talus, I use this SUV, which had helped me, sir.
Correct.
Otherwise, here it is just without any principles of planning cora, which we apply for doing an osteotomy. It is only a sequential soft tissue distraction based on at the rate what the patient tolerates. That was what I had done, sir.
Right. So the advantage of the SUV is when you use the Ilizarov, and if this is the tibia and if this is the talus, when you do a straight distraction, there is always a translation of the talus. It tends to translate anteriorly. When you use the SUV, you can do the distraction as well as you can program in the posterior translation. Is that right?
Yes,
Is
sir.
that, yeah?
Yes, sir. Yes, sir. That was
Yeah.
for which the SUV was used, sir.
Yeah. And then once you have achieved distraction, that means the soft tissues at the back are relaxed. Then under anesthesia, you just bring the foot like a Ponseti. You bring the foot into the correct position. We are not directing movement by the Ilizarov. We are just doing soft tissue distraction and then a gentle, what I like to call a repositioning of the foot. So in theater, under Siam, you check that the talus is in the right position. You check that, the forefoot is in the right position, right? Is that what you
Yes,
did?
sir. Yes, sir.
So the other couple of things, so one thing that this case has clearly shown is that even in older patients with very long-standing CTEV, if it's a congenital idiopathic, then just soft tissue distraction will also work, especially if they have not been operated earlier, right? And you've got a 5-year follow-up now to show a foot which continues to be perfectly straight. And the second thing is also the importance of maintenance of that. At least in the first 1 year, you need to maintain them first in a cast and then in a removable brace, because everything that you have distracted will tend to contract for at least a year. And you can get recurrence if you don't prevent them. But I think all in all, great result. So Krishna Kumar had asked a question and Sumanyu had asked a question which we've answered. Was it only distraction at the ankle with OrthoSUV and correction of angulation by manipulation under GA? The answer to that is yes. And Sumanyu from Orissa had asked, what is the advantage over classic Ilizarov? So we answered that by, what the OrthoSUV does is also builds in the posterior translation and prevents that crushing of the tissue on the anterior aspect. Arun Lal asks, congratulations for the toe flexor deformity. Did you do any release? The answer, I think, is no, he didn't do
No, sir. I
just
didn't do any release, sir.
manipulation when the fixator was being removed. And usually these will straighten out. I've had a couple of cases where it didn't straighten out, and there we've had to do an open release and then fix the toe to the metacarpal with a K wire. But I think compared to the overall problem, that is a minor thing. Okay, thank you. Great case, Kumar.
Thank you,
And finally, we have Hitesh. You can stop. Yeah, Hitesh, you can share your screen. Meanwhile, while he's sharing his screen, I will, Ankit has put up a clarification of his question. So he says, in one of the cases I did, after it was united, I took it out and put a nail from the top. And still that, in spite of that, some ankle valgus occurred. So there, again, the answer is that the ankle valgus and the proximal tibial valgus are a sort of inbuilt error of growth. Because there is varus here, these two epiphyses get programmed to grow into valgus to combat that varus, and they continue doing that even after it is healed. So you have to keep a watch on that, and growth modulation is the answer. Okay, Hitesh, go on.
Yes, sir. This 45-year-old male, he was assaulted by hitting by bamboos on the both legs. He presented with bilateral comminuted tibia fracture, and at the time of presentation, skin blisters were present, and skin was not good for the incision. So we have planned for bilateral Ilizarov fixator on the same sitting. This was the right leg. This is the X-ray picture and the clinical wound. This is the left side, and this is the clinical picture. So we have applied the Ilizarov fixator on this right side, and this is the clinical picture. Maintaining the alignment in the AP and lateral and neutral rotation with the principle of biological fixation. And this is the left side post-op X-ray and post-op clinical picture. So knee mobilization was started just next day, and physiotherapy was started. This is the 3 weeks post-op. At the 3 weeks, I started standing and touchdown weight bearing with the walk. At 1.5 months post-op, this callus was visible, so I started partial weight bearing. This is the visible callus. This is the left side, callus is visible. This is 2 months post-op X-rays. This is how patient walking comfortably with bilateral Ilizarov at 2 months post-operative. At 3 months post-op, right and left X-rays. This is the visible callus, good callus, left side. At 4 months post-op, at 4 months, this is how he is walking with full weight.
What happened? The thing crashed, I think. Your PowerPoint crashed, no?
Yes, sir.
Okay. But that was your last slide, no? Of walking.
No, no, sir. I will share post. So this is after 2 months post removal X-rays. And this is the knee range of movement after removal of the fixator. Thank you.
Good. So question then straight comes that you said obviously that because his skin was not good for incision, you said that we didn't do internal fixation. Suppose the skin had been good for incision, then you would have done internal fixation?
Sir, in this high energy trauma, I was in doubt whether these fragments will be vascular or not. So I will still doubt for the internal fixation, sir, because in one of the case, even I applied the Ilizarov fixator, I explained the patient preoperatively. These fragments were not healing, and they were getting necrosed, and pus discharge came. So that time I have to remove those fragments, and I have to do corticotomy.
Yeah.
So in these,
but that was in a open fracture or a closed fracture?
No, that was also, sir, closed fracture only.
Okay.
Skin condition was not good.
Right. I agree. I agree with you in terms of the fact that in grossly comminuted fractures, especially when it's over a long length, personally, I don't think there is anything like the Ilizarov. Just go back to your first or second slide,
Yes, sir.
which shows the yeah. Okay. Now here, if you look, you don't really have much hold on the proximal tibia. Even if you use a nail, there's going to be a problem. If you use some kind of a lateral plate also, first of all, there is a tendency to fix these in some element of varus. And this amount of comminution here, with the Ilizarov, the amount of dynamism that is available and the way that you saw the callus forming, I don't think anything beats the Ilizarov in having a dynamic fixation. Yes, it is an inconvenience to have the frame on the leg, but first of all, you don't often get bilateral fractures which are so comminuted. Usually it is one side. So to my mind, even if this was a closed fracture without any problems for fixation, Ilizarov would be very high up on my list. And now just go down the slides a little to show how you have done the fixation. Yeah, okay. So the other important thing over here is, this comminuted zone is entirely bypassed. We are not trying to fix it at all. You got good fixation on the proximal segment. And when you have a small segment like that with only one ring, you have used olive wires here to improve the stability. You have used drop wires to improve the stability, and therefore not disturb the biology of the comminuted segments. Now go to your last slide, the final picture, because Sumanyu has a doubt that the posterior slope is altered. So we have to clear Sumanyu's doubt, because that is very important. Sumanyu's doubts can never be left without, yeah, that one.
You are able to see?
No, not able to see. Just go back one. Yeah, this one.
Yes, sir.
Yeah. Now, so Sumanyu thinks that this is, but if you look at the long axis, the slope is okay. On this side, if you look at the long axis, also the slope is okay. So on both of these, anatomically, if at all, there may be a little bit of valgus on this side. on the right side, but the posterior slope is okay. And anyways, posterior slope, a little bit of variation, 4-5 degrees, even up to 0 degrees, I think personally doesn't make too much of a difference. So I think overall, excellent case. The important things to be kept in mind here are that you need to ensure. Now, sometimes what will happen is when you're putting the fixator on, the alignment may not be absolutely perfect. Then you can always put an OrthoSUV between ring number 1 and ring number 2, adjust the alignment so that it's perfect, and then replace it with straight rods once the adjustment is done. So I think that's an excellent case which shows the power of Ilizarov, this power of Ilizarov for the use in comminuted fractures. There is some questions on OrthoTV online from Milind Joshi. I think Milind is in Solapur. Will you wean the fixator or prefer to remove it at one go? I think this may be mentioned. This may be a question for Hitesh. So,
Yes, sir.
how do you remove the fixator? How do you decide that yes, now I can take out the fixator? So he's asking, do you take out part by part, or do you do what we normally call the stress test, confirm
Yes, sir.
that it is healed,
Stress
and then
test.
take it out?
Yes, sir.
So Milind, I think that, go on.
Yes, sir. First, patient was clinically well, so that was the first sign that I can remove and on the X-ray. Then after the stress test, gradually loosening the nuts and allow the patient to walk, and measurement of the collapse, how much it is collapsing, and then sequentially removing the rod, then removing the fixator if there is no collapse, significant collapse at the fracture site.
So all of this is done in the same day. Patient comes in the morning, you loosen, take it off, and then if everything is good, it's taken off, right?
Yes, sir.
If the patient has pain, etc., then we just retighten the rods and let them walk for another couple of weeks and then come back.
Yes, sir. So in this, I have removed the this bilateral leg at the 2 weeks gap.
Right.
To make the.
That's fair, yeah. So that you don't stress, make it difficult for him. So the other two questions I will answer. Any experience with matrix rhythm therapy to improve range of motion at knee? For tibia, there is no problem with range of motion. As soon as the fixator is removed, over a period of around 2-3 months, they regain full flexion, as you can see in his clinical picture. So this matrix rhythm therapy is not something that I'm a fan of. And same with teriparatide. Teriparatide has got no real role in terms of a fresh fracture. There are some case reports which talk about it in relation to non-union. But personally, I think if you are able to find what is the cause of the non-union and you treat those, then rarely that you need to use teriparatide. I have treated n number of patients who were treated, with conventional surgery and treated with teriparatide. Nothing has happened, and then we've treated it with appropriate principles and Ilizarov, and things have healed. Right. So good case, Hitesh. And then we will now finally go back to Divya, where he will share our experience of internal fixation. Should it be ever considered for infected non-union? Divya, you can share your screen.
Good morning, everyone. I'll be discussing internal fixation in infected non-union, whether this is really a scenario which is to be considered. So we'll try and recognize scenarios where internal fixation can be used in infected non-unions and describe the overall management scheme and principles, how we can carry it through. So the principles of treating the infection will remain the same. You need to debride it well, take out all the biofilm, take out all the dead and necrotic tissue, take out all the loose fragments and any foreign material which is there. the implant would need to be either replaced or you can retain it depending on how well the fixation was done. And you will also need to manage the dead space and manage the antibiotic long-term antibiotic use in consultation with an infectious disease specialist. The treatment strategy for the non-union will be maintaining alignment, restoring in alignment, getting good contact, and achieving absolute stability, add biology whenever there's needed, and maintain function and improve function so that overall good outcome can be achieved. So when can you really think of internal fixation? Is for infected non-union, external fixator remains the gold standard, but there will be situations where the patient is a poor candidate for external fixator. The size of the limb is too big. Even the largest of the rings or whatever fixation you are planning is at compromise, where the stability can be compromised. In periarticular situations where adding wires, transfixing the tissues can hamper your range of motion, which may be pertinent in certain cases to maintain for a good outcome. When there's a good soft tissue cover and more importantly, a limited area of infection, then you can think of internal fixation. If it's a large involvement in terms of the whole intramedullary canal being involved, then obviously it has to be a staged either an antibiotic coated nail and then converted to a internal fixation or supplemented with the external fixator. So we'll discuss two cases today. Case one being a 57-year-old lady. She had closed distal femur fracture 2 months back. This lock plate was applied with an interfrac screw. She developed a discharging sinus in 10 days. It was debrided and cement beads were put in, and then the beads were removed after 1 month. So she presented with a continuing discharging sinus and for an opinion what should be the next line of treatment. So the x-rays at that time were showing healing medially, anteriorly, and posteriorly, and already an debridement and cement spacer was done. So we decided to observe her for a while. The clinically infection was quiescent. CRP at that time was 9. The healing was progressing, so we allowed her to increase her functional activity and challenge it by weight bearing and see how things go. The further plan being, we'll stop the antibiotics. We'll see if the infection flares up again, and if there is no progress in healing, then we'll go ahead with the surgical options of removing the plate, debriding, and then replating. And if the healing progresses well without much exacerbations of infection, then once it's healed, the implant can be removed, and at that time debridement carried out should take care of the infection. But this was her clinical picture at presentation and the sinus which was there. So over a period of 2-3 months, the sinus really didn't improve much. The inflammatory markers were kind of remaining similar for about 2 months. And then she suddenly had a bout of continuing fever, general condition sort of not feeling well. She developed pain at the non-union site and her CRP had flared up. So since she was out of town and under care of the original orthopedic surgeons, he did a swab culture which showed Staph aureus, and antibiotic was started according to that. For another 3 to 4 weeks, the CRP was coming down. Her pain really didn't improve much. The fever did not subside. And then we decided to do a PET scan and see where all the infection is, which was largely limited to the area around the plate and a little bit on this lateral cortex area. The X-rays at that time, which was 3 months since she presented to us, showed progress in healing medially. Anteriorly and posteriorly seems healed, but this lateral void has not changed much since the time she presented. And her continuing fever, this time it was showing lysis around the interphalanx screw, which means that the situation is a little unstable. Instability will further add on to the infection. It will not let it settle down. Continuing antibiotics is just not the treatment. So we intervene at this point and take out the implant, do the debridement, remove all the biofilm. This is the lateral void which was left, which was already also seen on the X-rays. And so this is a potential area for a dead space. And we fixed it up with a lock plate. This time the plate fixation was improved. Earlier plate was way distally. It had questionable fixation in the distal, in the condylar region. We filled up the void with antibiotic stimulant and also laid the antibiotic stimulant over the plate anteriorly and posteriorly as well. Clinically, in the post-operative period, initially the CRP will go up for all the patients, but it starts coming down by 6 to 7 days. She continued to have some serous soakage from the incision side, and the CRP was going up despite her being on antibiotics according to the culture. So we decided to have a relook and did a redebridement. When we opened it up, there was a hematoma around the posterolateral aspect. There was, after clearing it out, there was some dead space there. So we washed it out thoroughly, took out whatever remaining stimulant was there. And this time we added a dependent corrugated rubber drain, which will then not allow any collection to happen in the space and allow it to drain posteriorly through the drain side, and if at all later it becomes a sinus. The dead space will have areas where proteinaceous material will collect and then can get infected again. This time again we added antibiotic stimulant as a measure to take care of the dead space, as well as add local antibiotic depot. Post-op X-rays after that showing the corrugated drain. The drain was gradually, incision settled, CRP started coming down. The drain was gradually withdrawn and pulled out. By 12 days, we could take out the drain. We sent the tip for culture. This time it showed no growth, and replaced it with a betadine wick dressing, which was changed alternate days to allow for to keep that track open and allow for any drainage, dependent drainage to come out through that. And eventually the incision had healed and no further collection was there. CRP continued to gradually decline, and once the CRP had come down, clinically everything was settled. At 6 weeks, we had stopped the antibiotics. CRP is normal, then the antibiotics were stopped, and the X-rays showed improvement in healing on medial side, anteriorly and posteriorly as well. The lateral side continued to show a little bit of the lateral void, which was there earlier. This contact had been improved. It continued to show a little delayed healing. But the radiological healing can be delayed in such situations. Gradually, the function improved, and the function was used as a measure of her improvement in healing. Eventually, 9.5 months follow-up, everything has healed well. No further interventions were done. Function improved drastically. Gradually, her walking, exercises, everything was kept a close watch on. And with the added weight bearing, the radiological improvement was seen. So the learning outcomes of this case was antibiotic is not the treatment of infection. Infection treatment is debridement, surgical debridement. CRP can be used as a prognostic factor to measure how the infection is settling or it's flaring up again. Keep a closer watch. You always reassess, relook, and redebride if required, because you cannot let these cases go on and dwindle out and procrastinate on that. Internal fixation in infected non-union can be considered when there's good soft tissue cover, periarticular regions, when there's limited area of infection, and if the size is too big for the fixator. But all this has to be supplemented by local antibiotics. You need to manage the dead space by beads or whatever other methods you want to use as dead space management. There you can use muscle grafts as well. If there's you can involve a plastic surgeon at that point in time. Appropriate antibiotics, IV or oral, recommended earlier consideration. If a sensitive organism is there, you have added local antibiotics, then once the CRP is normal, we can give it for 6 weeks and take it forward from there. Now the newer recommendations of fracture related infections, they are saying that we can continue IV antibiotics, IV or oral, whatever is available, for up to 12 weeks. We need to closely observe these patients clinically by hematological markers, how their function is improving, how things are going in radiologically, whether we need to add in bone graft at some point in time. And improving functional activity as a measure of progress can be used when there is delayed healing seen on the X-rays, provided the implant is holding well. If the stability is at compromised, then no question, it cannot be continued like that. So going on to the case 2, this was a 15-year-old boy. He had presented with a progressive femoral deformity. He had a fracture after road traffic accident 2 years back. This was a compound fracture on the right side, closed femoral fracture on the left side. Also had a compartment syndrome, vascular injury on the right side. Soon after the first surgery, he developed discharging sinus, which has been continuing since 1.5 years. He has had multiple procedures on this leg. This is a clinical presentation. The sinus was posteriorly at the posterior thigh, had a limited range of, this is all passive. He had no active range of motion. There was a flat foot drop as well. So again, the treatment strategy here was, because of the big size, we cannot use rings. If you are thinking of LRS fixator, then the issue is that because of such a big soft tissue, this thing, even the longest pins which are available, 200 mm, they are just reaching up to the skin in the proximal area. So question of inadequate hold. An osteopenic fragment distally, again, pins, possibility of pins backing out. So we thought about the internal fixation here, because again, this was a limited area of infection, no clinical skin and all soft tissues looked quiet. Introp, we did the debridement, took out the sequestrum, and reamed out proximally and distally up to size 13, used a thick 12 mm nail, achieved good maximum contact medially, anteriorly and posteriorly as well. There was this defect laterally, cortical defect laterally, but that was being protected by a thick nail. And because there was good thick nail and well filling the proximal canal, we just added one proximal dynamic locking. Distally though, this nail was chosen because it had this option of locking 3 bolts distally, adding that oblique locking hole. We can at times think of polar screws to reduce this, improve the fit in the distal canal. So the incisions, this was the lateral approach which was taken posterior to the zone of injury. That went on to heal well. The sinus started improving. Post-op X-rays showing that the reamings were put into that lateral defect as bone graft. Antibiotic stimulon was added there, and showing good alignment achieved and contact both anteriorly, posteriorly, and medially as well. So no further iliac crest bone grafting was added in this, because we had got good amount of reamings and we used it as the bone graft. Clinically, the incision, surgical incision settled well, but the sinus continued to drain out over a period of 2 months, and the culture had grown pseudomonas, and it was just sensitive to IV antibiotics. So we used a PICC line to continue long-term antibiotics. At 2 months, things had settled down, CRP had come down, so we gave him, we stopped the antibiotics, but asked him to continue with the wick dressing to keep the sinus draining, so that there's no further collection. But somehow at this point, the sinus had closed. He suddenly had a flare up of infection. There was fever. There was pain around that area. Also, he had infection in the PICC line, so that was removed. A new PICC line was, this time a central line was added, and an IND was done at the sinus to let it continue to drain. Once that was done, antibiotics were restarted, and this time we gave the antibiotics for further 8 weeks, and eventually the sinus also closed down completely. CRP came down to normal. Radiologically, healing was as it is progressing. It went on to heal well. The lateral defect continued for a little while, not a little while, for about 8 to 9 months, and then it started filling up gradually. Function started improving. Initially, he was kept in a below knee brace for the foot drop so that the gait can be improved. He has this proximal tibia varus from the epiphyseal injury at the time of the injury, which needs to be addressed at some point in time. And the X-rays are showing good healing at 1 year, and even the lateral defect has started to fill up. So the take-home message here was, again, keep the CRP as a prognostic factor. Internal fixation again can be done with under cover of good soft tissue cover in limited areas of infection, and we use the nail as a internal fixator here. It was a thick nail. We got a good contact, maintained alignment. There was dynamic locking to allow for that dynamic compression, and encouraged weight bearing from the time go. And distal lockings, 2 locks will not be enough in a wide canal. So you have to have oblique locking as well, or use polar screws to add to the stability in the wider canal. This has to be supplemented again with local antibiotics, dead space prevention, appropriate antibiotics. Here again, we gave it for 8 weeks initially, then the infection had settled. And again, we had to give IV antibiotics for 8 more weeks once it had reappeared. Continuing close observation clinically, hematologically, and a close watch on improving function and X-rays will help you to intervene timely if required and carry through with the internal fixation. Once the fracture has healed, and even if the infection continues, then the implant can be removed, and debridement done at that time will take care of the infection. With the implant being there and possibility of formation of biofilm, if there is any dead space, then yes, infection can continue. So one needs to then change the strategy. Thank you all for patient listening. Now we are open for discussion.
Thanks, Divya. So we'll take one question first, which is from YouTube. I'll allow Divya to answer that first, then I'll give my thoughts on it. For case 1, what would be the criteria to change to external fixation, if at all required? And I think that would hold true for case 2 also. What situation would you say that no, this internal fixation is not working, now I have to go to external fixation?
Considering external fixation again will bring us to the same discussion point which we started with, the size. Size will compromise on stability. So in situations of instability, internal fixation or any sort of fixation is not going to work in a non-union. So absolute stability is must. Once the CRP is
no.
our antibiotic is
Question.
going on.
One sec, wait. Question is different. Question is different. In that first case, in what situation will you consider, okay, that now my internal fixation is not working for whatever reason, and consider change to external fixation?
Continuing infection, continuing flare-ups, rising trend in CRP, the implant losing hold will be situations where we need to rethink, relook and go in again. At that point, we will have to consider the external fixator, or again an internal fixation, which is a rare possibility. But at that point, if we are again going in, we need to go in with all measures.
Correct. So one of the important things which some of you may not have noticed, especially in the second case, is that we've used a PICC line and things that have changed from earlier when we used to treat infected non-unions, and now when we are moving a little towards internal fixation, is very close cooperation with infectious disease specialist. None of these, in both these patients, we have used the help of an infectious disease specialist to the maximum. And that is very, very important. I don't even bother sort of in these particular patients thinking about what antibiotic, etc., is to be given. It's always the patient goes to the ID specialist, we discuss it with them, and then change the antibiotic according to them. So that's number one. You have to have, if you look at the AO trauma site, now there is an area, I think it's AO trauma/publications, where, or you can just message us and we'll send you all those publications, which have looked very closely at infection in the trauma scenario. Unlike infection in the prosthetic joints, there is also now a lot of advances in terms of infection in trauma. So there is very aggressive use of antibiotic in this patient. It goes without saying that your debridement has to be very thorough and all that. So in answer to sort of KK's question, if we have an organism which is very resistant to all the antibiotics, and in spite of good debridement, good local antibiotics, etc., the infection continues, then you are forced to think of external fixation, and then you have to do everything that is required, even with the big size and all that. Then it comes to external fixation. But in certain situations, like in the second case, one thing which was not mentioned, in addition to everything else, I usually say that, you know, patients actually force us to improve. This boy was from Lucknow, and in, I think, 2 months or so, he had his board exams coming up. And he was, the father was quite sort of insistent that if at all there is something that we can use for internal, you know, so that we don't have to come back frequently, that would be preferred. And that was one of the factors that came into the whole, in addition to everything else, the big size and difficulty, etc. That was also one of the factors. So internal fixation can be used if you get a good handle on the bug that is there, if your debridement, etc., is good, and you should be able to get extremely good stability. We used a big size nail. There was a lot of reaming, etc., that was done. So that is something that you know, you should think of. If it's a huge amount of infection, or bugs are not what do you call, bugs are resistant to all the antibiotics, then of course things may change. So this is not to say that yes, all cases you use. There is a certain limited subset where you can use internal fixation with a relative amount of safety. Now some more questions from YouTube. Could we have applied antibiotic coated plate? Could we have applied a longer plate up to the lesser trochanter? This is Sumanyu. Could we have applied an antibiotic coated plate? Yes, you could have, but I don't think there's too much of a difference between an antibiotic coated plate and a plate along with good debridement and stimulant beads. Essentially, both of them give you a high level of local antibiotic. So there's no real advantage to an antibiotic coated plate. Could we have applied a longer plate up to the lesser trochanter? Yes, we could have applied a plate up to the lesser trochanter, but there is no advantage to that. You use long plates when you're talking of the principle of fixation. When we are talking is what do you call that, relative stability. Here the principle we have used is absolute stability. So the plate that was used was long enough, as evidenced by the fact that it healed without any real trouble. Second question is the screw at the fracture site essential? Could we have applied vac dressing followed by a secondary closure? The screw at the fracture site is essential, yes or no, that is a sort of opinion. We used it because we were using the principle of absolute stability, and I thought that will improve our stability. Could you have applied vac dressing? Yes, you could have, but I don't think particularly it is necessary. If you can obliterate the dead space, there's no reason to use vac dressing. 4, could we have used an antibiotic coated nail initially? No. because an antibiotic coated nail is not something that is stable. An antibiotic coated nail is a space filler, and this boy didn't have intramedullary infection up and down. So he didn't require, and that is again evidenced by the fact that only locally he was having the recurrence of the infection, which could well be from just the fibrotic tissue, etc. Final question is from Yasir Siddiqui. What about staged management for managing infected non-unions? Removing all implants, dead necrotic tissue, and then going for definitive fixation and bone grafting. Yes, that is always an option. But in this particular, in these two particular cases, especially when it's periarticular, the moment you put a fixator on, that impedes their stability. And to a certain extent, I think it depends on your confidence in your own debridement. Meaning, if I am confident about my debridement, what am I getting by adding the second stage? Nothing. If I'm not confident of my debridement, or if I'm worried because of the bug, etc., then yes, using a two-stage makes sense. So if someone says that, no, I would prefer to use two-stage, I really don't have any argument against that. It's okay. It adds one more procedure. And if I have confidence in my ability to debride it, then I don't see a particular advantage. But for someone who's starting out, or someone who's worried, then yes, you can do a two-stage thing, you know. So that's not really nobody. I wouldn't object to that. This is just the way that we approach it. So I think if there's any questions on OrthoTV, Ashok or Neeraj, if you put it on, we can answer those. Otherwise, I think thank you everybody for a good bunch of cases which have looked at, you know, various aspects of trauma and deformity management, and hopefully you know, we should be able to get more similar cases for future. This is going to be an ongoing program which we will do on the first Sunday of every month from 9:30 to 11. This was our first sort of session, and therefore some of us have overshot time, etc. But we will see to it that, you know, next time we are absolutely bang dot in terms of time. And you can always email us at my email address, that's mangalparihar@gmail.com, with a suggestion for any particular cases, etc., that we want to see. Primarily, as I said in the beginning, this is going to be an interface between me, Divya, and the current fellows on this side, and the bunch of fellows that are already into practice, who are already doing good quality work. So it will be a two-way sharing. Fellows who are already practicing will be sharing their work, and we will be sharing what else we have been doing new, right? So thank you all, and we will see you again, I think, next, at the end of, rather at the beginning of the next session. So I'm ending the stream now. Apna Neeraj, if you can just stop streaming and give us 5 minutes on this thing. Neeraj or Ashok, stop the streaming, and then I just want to have a 2-minute discussion with the fellows.